like to ask, and maybe some blood investigation that will assist.
So as we can see, the acute presentation was actually history of blurring of vision with clumsiness for 5 days. And as patient is diabetic, so first and foremost, I would like to ask in regards to is any hypoglycemic symptoms at home, whether there's any tremors, any sweating, any hunger pangs, any midnight waking up for any food, and as well as the DXT monitoring at home. So that would be the first thing. And second, we also need to inquire in terms of his medicational intake, whether there's any traditional medication, whether he consumes any supplements or any recent change to his medication, and as well as history of alcohol consumption. And being a middle-aged 65 years old gentleman, I would also like to explore in terms of if there's any high-risk behavior associated with this gentleman. As well as mentioned earlier, there's no constitutional symptoms. However, he is an ex-smoker, and with the age of 65, I would like to inquire if there's any family history of any chronic disorders and or predominantly any malignancies.
Just to answer your question, so diabetic, yes. No any history of hunger pains, no hypoglycemic events prior to this. No history of traditional medications, and there's any history of malignancy in the family. There was no history of malignancy in the family. What else would you want to ask? I think I missed out one more. What was it? The one that you asked? High risk behavior. No, no high risk behavior. What else would you like to clarify with regards to the blurring of vision, perhaps?
So if in terms of blurring of vision, is it which-sided? Is it left-sided, right-sided, or which eye? And how acute is the presentation? And is it associated with any symptoms, for example, like headache, any features of raised ICP symptoms, such as vomiting and headache?
Okay, no raised ICP symptoms. There's no headache, no vomiting. But however, he claims when you say blurring of vision, his acuity is quite well. I mean, it's good, clear vision. Okay, what else do you want to see? If it's blurring of vision, he can see well. Acuity is still all right.
So probably I want to ask Dr. Shalini, right? How would you examine him if he were in and he actually complained of blurring of vision? Maybe you just tell us what are the examinations of the eye that you want to do.
Okay, so I would like to do a visual field assessment, visual acuity assessment, as well as proceed with cranial nerve examination and also a fundoscopy as he complained of blurring of vision, and he's also diabetic as well.
Right. Very well. So cranial nerves are also intact. Visual acuity is fine. Fundoscopy and visual field, okay. We'll show that in a later L. Any blood investigation you probably want to find out?
So in terms of blood investigation, other than the one that we have already displayed earlier, so I would like to take a HbA1c, infective markers such as ESR or CRP, and also to do an ECG to look for any evidence of cardiac arrhythmia.
So let me highlight CRP is still within normal range. ECG is normal, so no history of any arrhythmia so far in the wards. Okay, so let's see with regards to the visual field, yeah? So what would you expect in the fundoscopy? What do you want to look for?
So for the fundoscopy, as patient complains of blurring of vision with also diabetic, I would like to look for any diabetic retinopathy, such as any microaneurysms, any hemorrhages, cotton wool spots, exudates, and also to look for evidence of optic disc swelling, to look for any papilloedema.
Yes, still trying to rule out any raised ICP with papilloedema, okay? And also you mentioned about visual field, but usually as physician, we'll probably just screen. So the proper visual field will be done with ophthalmology referral. So if he had that, and the conclusion was left homonymous hemianopia. So what can you conclude from this left homonymous hemianopia? Where would you localize the lesion from here?
So there's no optic disc swelling, and the examination showed evidence of left homonymous hemianopia, which means the lesion would be present over the right optic tract.
Right optic tract.
So May I just ask something? Because we are not neurologists, and I see Prof. Tan and Prof. Azmin there. So maybe just let's focus on what our job in stake is, right? So you mentioned, if you go back the slide to the first one, and then I'll probably ask you what you want to, just the first, okay, oh, all right. So it's not written here, but it's over here as well, the case summary, right? So if we talk about the respiratory problem, right? So he's a 65-year-old man, of course, diabetes, hypertension, blah, 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 active smoker, da, 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 and chest radiograph showed right middle zone opacity. So maybe we just switch gear back to respiratory. What other investigation would you ask for? And how would you tie it in? Can move forward to the other slides, Azat, while she's thinking.
You see the right, okay, fine. So that's what I think.
So you didn't ask for it, but I think probably for the medical students, anyone who comes into ED, right? Basic investigations, the FBC, RP, LFT, and most people should get a chest X-ray. Okay, so Shalini, maybe you'd like
Would
to
you like to
comment on
describe
the X-ray?
this chest radiograph?
So this chest radiograph shows there's actually trachea is not deviated, it's centrally located. There's actually a singular mass located over the right perihilar region, over the right middle lobe. There's no other consolidation and there's no other mass seen, just a singular mass, and there's no evidence of cardiomegaly.
So how will you tie this with the visual?
Good question. So, 65 years old ex-smoker with a mass on the chest wall, the chest X-ray with history of blurring of vision and clumsiness. So I'm thinking in the lines of, could it be a lung malignancy with probable metastasis to the brain? Oh,
I think, Azat, you had the slide before that about the pathway, right? So,
So when you mentioned about the homonymous hemianopia, right? So we are suspecting something within the right side of the brain, left hemianopus, or right side of the brain, hospital lobe, right optic tract. So you along that side. So you're suspecting something will be there. We usually call it space occupying lesion, yes. And then you see with the chest X-ray, sudden mass over the right hilar region. So now you're trying to tie those two up, whether they're related, whether this is, what would your differential be?
okay. So at this point of time, my differential diagnosis would be, could be a primary lung malignancy with metastasis. I'll also investigate for pulmonary tuberculosis with probable tuberculoma, and it could also be a lung infection, unlikely, but one of the differential down the list would be probable lung abscess with dissemination to the brain, but primarily because it's a solitary lung nodule present on the chest X-ray, so I'm thinking of primary lung malignancy with probable metastasis to the brain.
So we go on priority because of the age, the diabetes, the history of smoking, ex-smoker, active smoker. So that's why priority will be in your malignancy with the metastatic brain. Then again, diabetic, age, infection will be there, lung abscess can be there. If it's tuberculosis, common in Malaysia, so you still need to rule that out. All right. So to get further input,
yeah, okay, all right. So I'd like to invite to the stage our sole representative from radiology, Associate Professor Dr. Soraya Aziz. Soraya, when you go up, maybe you can just give Shalini some marks first in terms out of 5, her interpretation of the chest X-ray before you move on. Thanks. So this will OSCE can describe the chest radiograph above. 5 marks. How many would you give her? Shalini?
Oh, the marks.
Marks. How many marks would you give her for describe? Shalini, describe it again. Get your 5 marks.
This is a chest X-ray. It's not rotated.
0 marks.
One more.
Oh, 1 mark. Okay. The trachea is centrally placed. It's not no deviation of the trachea. The heart size is normal. There's no evidence of cardiomegaly. There is a singular right perihilar mass located predominantly over the right middle lobe. Well-defined and rounded lesion with no other collapse or consolidation seen elsewhere, and there's no bone lytic lesion as well seen.
Would you consider the mass speculated, Dr. Shalini?
No, it looks rather well defined and circumscribed to me.
Okay, Dr. Prof. Soraya.
Okay. Excuse my voice, actually. I think for Shalini, we would like to address the mass as, oops, sorry, be in the, oh, where is it now? I've gone very far.
The other direction.
Oh, the other direction. Should be in the left mid zone rather than a left middle lobe. Because right middle lobe. Because we just would like it to be separated as in upper zone, mid zone, and lower zone. That's the safer way to describe. Okay, but
marks,
otherwise I would give her full marks. Okay.
No clapping.
To the next one. Yep. Okay. All right. So we'll move on to this because he had the blurring of vision. Yeah. So they requested for a plain city brain. So can you describe?
So the plain city brain shows there is actually a singular hyperdense lesion located over the right parieto-occipital area with actually perilesional edema, and it's encroaching onto the right lateral ventricles. Yep. I do not see any obvious midline shift here.
So what do you think about it?
So I think this could be a space-occupying lesion, and could also, my differential diagnosis could also be because the subsequent, the next slide shows more of heterogeneous like lesions. So I would say could be infection as well, could be lung abscess, space-occupying lesion. Infections such as brain abscess or like cryptococcal.
White cells 8.8, Shalini.
Okay, so then my differential diagnosis predominantly would be around the lines of malignancy, such as space-occupying lesion. So lung malignancy with probable metastasis to the brain. But to further evaluate, I'd like to get a CCT brain or an MRI in this case.
I think we proceeded to MR at the end of the imaging, but before that we did. Oh, okay. So this is my description, and you rightly so saying that is a hyperdense lesion, okay, and the Hounsfield unit for this lesion is about 53 to 60. So that is that corresponds to a hemorrhagic mass actually, and there is a significant white matter edema, and it's sitting at the occipital region, right occipital region. However, there is no midline shift. I didn't give you a bone setting to just check whether there is any skull lesion. But anyway, we would have the MR later. Okay. So next, actually, we had a CT thorax because of the probable diagnosis that you mentioned just now. Do you want to describe it?
So for the coronal view of the CCT thorax, there's actually a hyperdense lesion located over the right perihyla, over the right upper lobe of the chest of the lung field. However, that's from the coronal. From the axial view, there is also a similar hyperdense lesion, and it's actually closer towards the chest wall, located over the right upper lobe. As you can see, there's also two ipsilateral lymphadenopathy present as well. I do not see any pleural effusion from the CCT thorax.
This CT thorax, there are two settings. This is the window, what do you call it? Mediastinal setting, and this is the lung setting. Okay, so for the benefit of the medical students, so this is an axial section, and this is a coronal section, and this is a corresponding axial section in lung setting. And on the mediastinal setting, you can see that there is a heterogeneously enhancing lesion. So you can see the center of it looks a little bit more hypo as compared to the periphery. So we call it as a heterogeneously enhancing lesion because the hypodensity does not looks like a fluid density to call it an abscess. Okay, and when you look at the lung setting, you can appreciate that there are some speculations, and there are two small lung nodules. Okay, and there is no other lung nodule in the contralateral lung. There is also enlarged precarinal lymphadenopathy, as what Shalini mentioned just now. So all in all, it's pointing towards a lung malignancy, and there is encroachment of the chest wall. However, there is no extrathoracic extension. Okay, thanks. Shall I move on to the next one? Okay. So, okay. We've mentioned that. So this is the MRI brain that they did afterwards.
Okay. So from the MRI brain, I can actually see a multiple ring enhancing lesion. There's two located over the right frontal lobe. Then there's two here, one here, another one here, two different locations. So there's two right frontal lobe rim enhancing lesion, and there's also another one located over the right cerebellum, and here would be right occipital area, also ring enhancing lesion.
Okay, so sorry. So what do you think?
So with
CT.
yeah, so to tie up from the lung, from the chest X-ray, from the CCT thorax MRI with patient's presentation, I would say this would be a primary lung CA with metastasis to the brain.
So can I just ask Dr. Soraya, Prof. Soraya, could we have gotten away without the MRI brain?
We could have done a contrast enhanced CT, but I wonder whether the smaller lesions could be picked up on the CT itself.
Okay, thank you.
So MR is the best modality. Okay.
Okay,
I
thank you.
think that's about it. Okay. So yeah, so we have a multiple rim enhancing lesions in the supratentorial as well as infratentorial region, and you rightly pointed out they are in the right cerebellum, right parietal occipital region, and two in the frontal lobe. And the characteristic of it does not correspond to abscess, given the history and what we found. So it's most likely representing brain metastasis in this patient. Okay,
Thank you.
that I thank you.
Okay, thank you very much, Dr. Soraya. So back to you, Shalini, and Dr. Azat.
All right. So, given the imaging that you've gotten, thank you, Prof. Soraya, what further investigation will you do? Since your diagnosis now is provisional diagnosis.
So my provisional diagnosis at this point of time would be a lung malignancy, primary with brain metastasis. So I would like to take a tissue sampling for this patient, as I know there's evidence of mass both at the brain and at the lung.
Which one would you take? I think Prof. Ramesh is here. So do you think he went in to get it or somebody else went in to get it?
Okay, so as from the CCT thorax, we can see that the mass is actually located towards the chest wall, and it will be less invasive to take from the lung rather than the brain. So I would proceed for a CCT guided lung biopsy for tissue sampling purposes.
So again, the primary here, you're thinking whether it's lung or the brain.
Primary would be lung. The reason is because it's a single solitary nodules, and brain has multiple ring enhancing lesions. So putting that into picture, I would say lung would be a primary and with the metastasis to the brain.
So usually I will ask this prior, but I think we'll let Dr. Azian probe you further in that.
Okay, all right. So I'd like to invite to the stage Dr. Aziani Yahya, histopath from Hospital Chancellor Tuanku. Thank you, Aziani, for agreeing. Shalini, don't go anywhere. You will be asked some questions.
Okay, Assalamualaikum and good morning, everybody. So on the 16th of January 2024, we received a specimen of right lung mass biopsy. So it consists of 2 small fragments of tissue entirely submitted in one block. Okay, so this is the lung biopsy specimen. So, Shalini, what would you expect to see in a lung biopsy specimen? Let's say, what is your differential?
So probably, so this is just a learning point, right? When you actually ask for a biopsy, you must know what you're looking for. So Shalini will now be able to tell us what she thinks she's going to find. Then only you'll get excited about the results, right? So never ask for an investigation if you don't know what to expect. I think that's a bit unfair.
Okay, HP is not my cup of tea, but I will try. So, as we do have the slides here present, I think for lung malignancy tissue, HPE, what I would look for is for glandular formation, typical like acina glandular formation, any mitotic cell seen, hyperchromatic, if there's tissue necrosis seen on HPE. But from here, I can see there's
This is low powered, so probably not much.
okay.
So Aziani, how many marks would you give her out of 5?
Okay, considering this is not her cup of tea, so I probably give her 3 marks out of 5.
All right,
Okay.
passing mark.
Okay, so this is what we see in the lung biopsy specimen. So we're lucky we get the lesional cells, okay? Okay, so as you can see now, these are the fragments of fibroadipose tissue. So these are the fat area, and these are the fibrous area, okay? So you can see there are malignant cells infiltration here, as well as some in here, okay? So there are no normal lung tissue present within this biopsy. Okay, so this is the higher magnification. So as you can see here, these are the atypical malignant cells infiltration. Okay, they are forming some vague acina pattern. Okay, nests of pleomorphic cells. Okay, so these cells, they display moderately pleomorphic and large hyperchromatic nuclei. Okay, we cannot see any prominent nucleoli, and in areas we can see occasional mitosis. Okay, so this is a very small biopsy, and the malignant cells are quite scanty in this specimen. Okay, and then the stroma around the malignant cells, they show desmoplastic reaction. It's a fibrotic reaction that is normally seen around tumor cells. Okay. Oh, okay. Okay. So at this point of time, your differential would be?
Maybe you can just look at the slides. What is it? And what parts are you excited about?
The IHC stains where the CK7 is.
Can you use the pointer to tell me where it's positive? Where does it stain? That one I dare ask because I also know it myself. So, okay. Yeah. So anything brown? Aziani, betul tak? The brown bits, is it? Okay.
Yeah, the brown stained area.
I've been given the mic, so I think I can walk. You need to do better than Brown. You are a registrar in Medical 1. You can see the one at the bottom, right? Negative, positive.
Okay,
so
so
what does it
the
mean?
so the immunohistochemistry stains would actually differentiate whether this is a primary lung, and it actually also helps us to differentiate whether this is an adenocarcinoma or could it be a squamous cell carcinoma.
Yeah, so I think the adeno was in the previous slide, as in the shape of it, right? The shape of the adeno is like glands, right? Betul. Oh, thank you.
Okay, so from the biopsy, from the morphology of the tumor cells, adenocarcinoma would be our first differential. Okay, for squamous cell carcinoma, usually we would see diffuse sheets of malignant cells, and if you are lucky, we can get some keratinization, intercellular bridges, which are not present in this biopsy. And there's no neutrophils infiltrate or neutrophils aggregate to suggest lung abscess. And there was no granuloma seen in this case. Okay, so we proceed with the immunohistochemistry to see where is the primary. Okay, so first we would do CK7, CK20. This is done to, because there are differentials, if we see CK7, CK20 staining. Okay, so in this case, CK7 is positive and CK20 is negative. So, and then the P63 is for squamous markers. It shows some positivity. Okay. However, in this case, TTF1, which would tell us lung primary, is negative. Nepsin A, which would confirm the adenocarcinoma nature, also negative. And we do synaptophysin and chromogranin just to exclude neuroendocrine carcinoma. These are all negative. Okay, so from the lung biopsy, we think it's adenocarcinoma, but we couldn't prove it with TTF and nepsin to show that it is a lung primary. Okay. Okay, so this is what we reported from the biopsy: polydifferentiated non-small cell carcinoma favoring adenocarcinoma. Okay, and then we think it's from lung primary. Okay.
Okay. Thank you very much, Azian.
Okay. Okay, so on the 26th of January 2024, we received specimen labeled as brain tumor. So it's a piece of grayish tissue measuring 2 centimeters, entirely submitted. So now we have more tissue to play with. Okay, these are all fragments of brain tissue. Okay, infiltrated by malignant cells arranged in diffuse sheets. So what you see here is mainly the malignant cells infiltration, and there are areas of necrosis. Okay. Okay, again, higher magnification. So these are all the malignant cells arranged in sheets. Okay, they display moderate to severely pleomorphic and large nuclei. Okay, and then there is prominent nucleoli, and then there are also a lot of mitosis seen. Okay, higher magnification, just to show you, this is one higher power. There's a lot of mitosis. These are all the mitosis. Okay, and these are the malignant cells. They are very pleomorphic and large nuclei, and there are nucleoli present. And this is the area of necrosis, tumor necrosis. Okay, and we proceed with the immunohistochemical study. Okay, so in this specimen, the CK7 is strong and diffusely positive. So the brown staining indicates positivity of the tumor cells. CK20 is negative. Okay, TTF in this specimen is diffusely positive. So they show nuclear staining. Okay, these are all the malignant cells with TTF1 positivity. And nepsin A is also positive. It stains the cytoplasm of the tumor cells. So with the CK7 positive, CK20 negative, TTF1 positive, and nepsin A positive, it points highly pointing towards lung malignancy. Yes?
Only one question allowed in view of time, Shawal.
Okay, it's only 8:30, right? So, so I need to ask a question because it's a burning question. Yep. We already have biopsy from the lung, right? Which shows adenocarcinoma. And if I put my money on a lesion in the brain, it's going to be adenocarcinoma. So why do we still need a brain biopsy? Because, the brain is a very delicate. Yeah. So.
So very good question. I think for all of you who were thinking about it or too shy, you should buy him coffee for actually Nikan. So who wants to answer? You're both fighting. Only one person gets one. Are you going to address it in your talk? Okay, so hands up, Yuman, Dr. Marfu'ah or Prof. Ramesh to answer? Dr. Ladies first. Okay, all right.
I think I'll just fill in some gaps in the history. So basically, the initial presentation was to the neurosurgery. So it was actually in the neurosurgery, and then patient had surgery to the brain. That was the first presentation. And then we saw the lung mass. And I remember the CT scan that we first saw, that was the solitary lesion. The MRI was actually in April, so that was 3 months gap. So between that, there's another CT brain that shows recurrence in March. So then he had another second surgery, and the MRI is the one after the second surgery. So I'll pass to Prof. Ramesh.
May I? Okay. Sorry, just to answer the question. So I think the first time neurosurgery, actually Prof. Azizi operated, I operated the second time during the recurrence. So during the first time, the patient presented with the left homonymous hemianopia. And if you look at the scan, like the radiologist pointed out, it's very bright. So the patient had a hemorrhagic bleed into the tumor, and certainly with a lot of vasogenic edema. So we see a lot of edema like that, we always think of mets or abscess, but it pointed more towards mets with the lung lesion. So I think there was enough indication to operate, because you can ask why operate on the brain tumor, take the lung biopsy at the same time. So that's the first comment. The second comment, I think we were asking just now, whether could it be primary brain or could it be primary lung? Just for the benefits of the medical student, brain tumors tend not to metastasize. They can become multifocal, but they stay within the brain. They don't go to the liver, lungs, or anywhere else. That's very unique of brain tumors. They can seed down the spinal cord, spinal column. Yeah, they can sit down, but they do not go outside. So for us, when we see lesions like this, we would think more towards secondary rather than a primary brain tumor.
I think this is the importance of sequence or events in getting a good history, right? So I think Shawal not very happy because we put it all, but it was intentional just to see whether he was paying attention.
Okay, so I move on. Okay, the P63 immunohistochemistry is scatteredly positive. Okay, this can be seen in adenocarcinoma. CK56, also a squamous marker, is negative in this case. We did mucicarmine. This is to highlight mucin production by tumor cells. However, this is negative. Okay. GFAP, this will highlight the brain tissue. It shows some positivity, meaning the normal brain tissue is picking up the stain, whereas the tumor cells are negative. We did other immunostains, CQ20. Okay, CQ20 is negative. S100, melan, and HMB45 for melanoma are negative. Okay, PSA, this is for prostate, also negative. Okay, diagnosis is consistent with metastatic carcinoma of lung primary. Okay.
Okay, thank you very much, Aziani.
Thank you, Dr. Aziani. All right, so yeah, just to recap again. So the lung biopsy was done, followed by the brain tumor. Mini craniotomy was done by Prof. Azizi, Prof. Ramesh mentioned just now. So what would you want to do once you have a diagnosis of adenocarcinoma? What else do you do that is commonly practiced here before we call upon our oncology colleagues in one setting?
Okay, so now that we have the tissue sampling and the HPE slides were actually presented already, so the next subsequent step is actually to send for driver mutation testing. And the one that's available here that we do is EGFR, ALK, ROS1, and PDL1.
Okay.
Yes, and then to proceed with CTTAP for staging purposes as well.
All right.
Okay, so I'd like to invite to the stage Dr. Marfu'ah, who is the oncologist, and we usually work quite closely with her in terms of which of the driver mutation to send. So maybe just of note, that one is sent out, it's outsourced, and it costs a bit of money. So that needs to be factored in as well. Okay, Marfu'ah?
Okay, so what do we know so far? So we know that this is a middle-aged gentleman with very acute presentation, and even though he has a lung primary, he has not much symptoms from the chest. He has multiple comorbidities, but he's otherwise well. I think all the blood tests shows very good organ function. He was still driving, he was still actually jogging before the diagnosis. He had upfront surgery, and also he had a biopsy of the lung, okay? So that both showed the same diagnosis, which is a primary lung cancer. Okay, so why is it important to do mutational studies? Because now lung cancer treatment really depends on which molecular type you are, okay? Previously, we see lung cancer as a one entity, but nowadays, and then we move on to seeing whether it's a small cell, is a non-small cell, or adenocarcinoma, large cell, or squamous cell, because they carry different disease characteristic. They have also different resistance or also sensitivity to treatment. Okay, and just for the non-oncologist, PD-L1 is actually showing your response or treatment sensitivity to immunotherapy, which is the new kid on the block for us. Okay, so one thing I would like to highlight is that the patient presented in January, and we actually saw the patient somewhere in early March. So the problem, before I get on to the case, the problem with lung cancer is that it's almost always late presentation. We hardly see stage 1 diseases. Okay? And because mainly they are asymptomatic, you see this guy, he had brain metastasis, but he has nothing from the respiratory symptoms. It's also very aggressive. 80 to 90% of the time, the patient has already metastasized. And also it's very rapid progression. You see between January, it was a solitary brain lesion. Up to March or April, it's already metastasized multiple brain lesion. Okay? It has a very high metastatic potential, not just to the brain, it can also match to almost everywhere, including the adrenal, which is very unique for lung cancers. And what's also difficult is that unlike certain other tumors like breast or colon cancer, treatment is very complex. So it's not a straightforward or one-size-fits-all approach. Okay, so it's actually very, very common to get brain metastasis as initial presentation. Okay, and it carries poor prognosis because of the neurological impairment, and also most of our treatment for the brain, for the lung cancer, doesn't penetrate the brain. Okay, so it has most of our chemotherapies, immunotherapies doesn't have the ability to penetrate the blood-brain barrier, and this occurs predominantly in most of the histology. So about 40% of non-small cell and higher in small cell lung cancers. Okay, so I've showed this before, and I would like just to highlight the ALK and EGFR. So these are the subtypes that actually have molecular tyrosine kinase inhibitor that can actually penetrate the blood-brain barrier. So if you have EGFR positive or ALK, that's treatment that can also penetrate the brain and also treat the systemic disease as well. Okay, so normally in patients with brain metastasis, the survival is poor. They generally survive only about 1 to 2 months after the diagnosis of brain metastasis without treatment. Okay, so how do we decide what to do? It's very important to know all of this, whether the patient has good performance status, okay, number and size matters, and then we also need to see whether extracranially is the disease very heavy. So if you have very bad brain metastasis, very bad liver metastasis, then I think we know that most likely this is going to be very comfort care. Also looking at your treatment modalities. In lung cancers, we have different treatment. As I mentioned before, there's targeted therapy, there's chemotherapy, there's immunotherapy. Even for the brain, okay, we have different modality of treatment. Okay, so the first two is radiotherapy. So you use radiation to kill the cancer cells. But what is different between the two, whole brain radiotherapy and stereotactic? Whole brain treats the whole brain. I mean, it's in its name itself. Okay, and then stereotactic just focuses on the area of the tumors, sparing the normal brain. Okay, then we have surgery. Okay, and we can also use systemic therapy, as I mentioned before the targeted therapy, EGFR and ALK TKI, and you can actually use combination of all this treatment. Okay, so when do we do gamma knife or stereotactic radiosurgery? Mainly when you have multiple lesions, especially the lesions are big, some are big, okay, because you can give higher dose to this lesion. Also in areas that you cannot operate, okay, in the brainstem, these are areas that's good to use stereotactic radiosurgery. When do we give whole brain radiotherapy? So extensive bone metastasis, especially when you see in small cell lung cancer, when there's leptomeningeal spread, and as I mentioned, if there's extensive extracranial disease, or the patient who has very poor performance status or multiple comorbidities that makes the patient unable to receive systemic treatment for the lung cancer. When do we actually go for surgery? So I haven't put here, basically hemorrhages. So hemorrhages from the brain mets, that's when to operate. Any mass effect, hydrocephalus, or when you actually scan, you can't see any other lesion elsewhere. So it's only in the brain, you need a tissue diagnosis, then that's also an indicator to operate. Okay, when to use just systemic therapy? So I mentioned to you before, EGFR TKI and ALK TKI, especially in the third generation, the better ones can actually treat the brain as well. But normally for this, we prefer to use this when it is small asymptomatic metastasis. So big metastasis is not very sufficient to use systemic therapy as well. Okay, so for the systemic disease, okay, don't worry, okay, you can just send to us, but just to highlight that it's emerging, it's no longer one type chemotherapy. Okay, so when I actually graduated, it was a lot simpler, and now it has really emerged into until about 3 pages of journal article. Okay, so going back to this patient, it's not always straightforward. So the patient has very good performance status. It was actually solitary mets to begin with, but then remember he had 2 months gap, and when we look back, the MRI showed multiple brain lesions. So this is considered still oligometastasis. He has only a lesion in the lung. We didn't see any much. I don't think he has any liver metastasis or adrenal metastasis or even bone metastasis. Okay, and the patient is not suitable for EGFR or ALK TKI. He has high PD-L1, meaning that he is suitable for immunotherapy, but immunotherapy doesn't penetrate the blood-brain barrier, so it's not going to treat the brain metastasis. Okay, so because of the progression, in the end, the patient had a combination of all this. So the patient had surgery again because of the fast progression, and then followed by immediate radiosurgery, and then going for systemic treatment. Okay. So I just would like to highlight, in terms of the diagnosis, Dr. Shawal was asking before, do we actually need both biopsies? Actually, if it were to be communicated earlier, I don't think the patient needs both biopsies, because for the medical student especially, when you look at something and it appears like something like lung cancer and behaves like lung cancer, most likely it's lung cancer. Okay, time is gold for malignancy. Waiting 2 weeks or 1 month will really have a huge impact for the patient. And then what used to be a very poor survival, or a death sentence to patient, now this might not be so soon. Okay, so, and I would like to highlight, we should really communicate between us. Okay, always work together, have your MDTs either formally or in the corridor or by the bedside.
Okay, thank you very much, Dr. Marfu'ah.
Thank you very much, Dr. Mar. Yeah.
I think
so,
in the interest of time, maybe we will invite our star guest speaker.
yes.
So I'd like to invite on stage Associate Prof. Dr. Ramesh Kumar, and he will be our last speaker, then Azat will tie up.
Thank you very much, Prof. Andrea, for inviting me. Okay, just move on. Yeah, so just to highlight the sequence of events, so the first time the patient presented with the left-sided homonymous hemipnopia, had a right-sided occipital hemorrhagic lesion and lung lesion. So craniotomy was done, biopsy was done, and then we subsequently had the diagnosis. However, the patient had recurrence. So I was involved in the second surgery when we resected the occipital mat, and then we discussed treatment options for the patient. So this was the original MRI that was presented. You can see this brightly heterogeneous ring enhancing lesion, which with a lot of edema as well. This was when the patient recurred. Just when I went in for the second surgery, you can see it's quite a big recurrence. And I think features in keeping with adeno-CA, with this big cystic cavity in the middle. So a bit about Gamma Knife. So we are very fortunate we have a Gamma Knife center here. And I invite all of you to come and see us treating patients. It's all over in half a day, pretty much. The Gamma Knife machine looks like this. It's like very much like a CT or a MRI machine. You have the bed end on one side, and then you have the block where all the radiation is. And we are very fortunate this also has a CT scanner. So how does Gamma Knife work? I think this is a very nice analogy. If you imagine the sun as the radiation source, the cobalt gives off gamma rays, and what the machine does, it focuses it on one point. One of the advantages of Gamma Knife, it is painless, very short recovery time. In a lot of countries, patients go back to work the next day. So it's very attractive as opposed to having a craniotomy, being in hospital between a week to 10 days, and then back to work in about 2 to 3 months' time. No GA required except in pediatric cases. It has less side effects compared to conventional whole brain radiotherapy. You very rarely suffer the side effects of hair loss and neurocognitive problems when you give a Gamma Knife compared to whole brain radiotherapy. And it's a very good alternative for inoperable cases. And the other big advantage, we can treat multiple lesions. It's very difficult to do multiple craniotomies. So this is the inventor of the Gamma Knife, Lars Lexell. It was during the time of heroic neurosurgery when morbidity and mortality was very high. So two things, he learned how to use high energy to treat tumor cells, and he invented the frame. The frame is very important because it gives us X, Y, and Z coordinates to localize anything within the brain. So two things, he gave us the frame and radiosurgery. So this is what the machine looks like. It is very accurate. You're looking at sub-millimeter accuracy. So we use 192 cobalt sources. This is at the head end of it. It's arranged in 8 sectors, 5 rings, so 24 cobalt sources, and they all focus to one point. Let's skip this. So how do we do Gamma Knife treatment? In the morning, we put on a frame. The patient then goes on to have the MRI or angiogram. Then there's a break where we do planning. So during planning, we put all the shots or doses that we want to treat. The plan is checked. Once everyone signs off, the patient goes into the Gamma Knife machine. The doors slide open and the patient gets their treatment. So it's all over in one day. At the end of the treatment, we remove the frame. Patient is observed for about 2 hours and then discharged. So while Gamma Knife is very attractive, but we can't treat everything. So there are very specific indications. So traditionally, we always think radiation with tumors, but in fact, it's more than just tumors. So we treat most of the benign tumors, schwannomas, meningiomas, pituitary adenomas, and you can see metastasis is in the list. Metastasis is the commonest brain tumor. You get lots of brain tumors, it's the commonest brain tumor. And for most Gamma Knife centers, the bulk of their work is treating metastasis. And the results are very encouraging. We can treat ocular melanomas and now recently gliomas, although currently it's still salvage therapy. And then we have a whole range of vascular problems, AVMs, cavernomas, AV fistulas, glomus tumors. And then we also treat functional disorders, things like facial pain, trigeminal neuralgia, essential tremors, some cases epilepsy, OCD, and one of the newer indications now, hemifacial spasm. So coming back to our patient, so I just put in the arrow so you can see there's a patient had total of 8 mets when we decided to do gamma knife treatment. So this was the resection cavity, so we consider that as one of our mets that we want to treat. You can see 2 of the right frontal lesions the patient had and an occipital lesion here as well. I always tell the students are very easy to read brain scans. Luckily, we have 2 halves. Sorry, I know got radiologists here today. But basically, you have 2 halves, you compare one side to the other. If it doesn't look right, the chances are it's not right. Okay, so this is what a plan looks like. Something from your geography class. You see a lot of these lines, which we call contours. So it just tells us where the radiation limits are. So basically, for brain metastasis, we would give anything from 18 to 22 to 24 grays, depending on the size. The smaller the tumor, the higher the dose the radiation we can give. So the gray is a basic unit used by the oncologists for radiation. So generally, the brain can tolerate point dose of about 8 to 10 grays. So for metastasis, you can see we give almost 3 times the dose. So we did two treatments for this patient. He had a total of 8 lesions. So the first treatment, we treated the occipital and frontal, and then 2 weeks later, we treated all the other lesions. So because it was multiple, and because the occipital lesion was very big, so that's why we did it in 2 treatment sessions. So just very quickly to finish off, so we have got very good success with brain metastasis. This is a very extraordinary case we treated. So we treated a total of 33 brain mets in 2 sessions, and you can see you had marked resolution in these lesions. So this was a case of lung cancer. Unfortunately, for our patient that we treated, I don't have the follow-up scan because we only did him in April. And normally for metastasis, we follow up every 3 months. So this is another case, colorectal cancer we treated. Again, very big lesion, so you just focus. So this one, we did it in 3 fractions. 3 fractions means we did it 3 times. We divided the dose. So this was during the first treatment, the size, second treatment, and third treatment. So even in large metastasis fractionation, we see very good results. This is a case of breast cancer with multiple mets that we treated in 3 sessions. And you can see what we started off with the original volume and the final volume, more than 90% reduction in the sizes of the mets. We've also treated orbital mets as well. This patient had 17 brain mets we treated. So you can see there is a large met here in the eyeball. And again, this is what the ophthalmologist saw at the beginning, and that's what they saw after almost about 3 weeks to a month later. This patient also responded very well for the brain mets. And finally, I want to leave you with a very special case we did, a case that's very dear to me. It's only second time in the world it's been done. So this is a very unusual case. So this lady presented, she was 28 weeks pregnant, history of breast cancer, and it was her 3rd recurrence. So she came in when I was on call, very unsteadiness, headache, and she had this solitary lesion, and she had bled into it. So then we discussed various treatment options. Unfortunately, she had a lot of metastasis in the lung as well. So to operate would have been very difficult because we have to go prone, basically face down, and she's 28 weeks pregnant. The other option was to operate her on her side, which would have been very challenging as well. So since we had gamma knives, so we decided to had a MDT meeting. As Dr. Marfu'ah said, it's very important that we all talk to each other when we are planning these cases. So you can see this is a very large met we treated. This was follow-up scan a month later, and that's 3 months later. So she went on after her gamma knife to have further chemotherapy and subsequently delivery of her baby, and it was a very successful result. Okay, so very gratified mother and satisfied family. So just to summarize, when it comes to brain metastasis, because the thinking is changing a lot, so they are very ideal targets for gamma knife, but they are very specific indication, as Dr. Marfu'ah said. If you got leptomeningeal disease and multiple brain mets, then you have to consider whole brain radiotherapy. We published case of 33. We've done 40 over now. And recently I showed Dr. Ma, somebody in the world is doing 93 brain mets. So I don't know where the limits are at the moment. You know? So we can treat multiple brain regions. Numbers is no longer an issue already. We can even treat larger lesions. Last time the cutoff used to be 3 cm. We can treat bigger lesions now. We can retreat when tumors recur as well. We can treat post-resection cavities, like in our case as well. And previous radio-resistant tumors are no longer the case. Almost any tumor now, mets, we can treat with gamma knife. Surgery still has a low role, as we mentioned, large symptomatic brain mets. Thank you. Any questions?
Okay, thank you very much, Prof. Ramesh. So now we are smarter lah in terms of the gamma knife. And I managed to bump into you, and that's how we realized that there is a whole world. So perhaps you can visit the Gamma Knife Center. Thank you, Prof. Ramesh.
Thank you.
In the interest of time, we are 2 minutes over. Shalini, you're off the hook, no more. Azat, sum up.
Right. So basically, summary patient presented with a visual defect, left homonymous heminopia, discovered then both he had brain and lung lesion. CT imaging was done, patient biopsy was taken, treated as a stage 4 disease, underwent a craniotomy, second CT brain showed recurrence. So that's when the MDT came with oncology and neurosurge. Patient was decided for another brain excision, tumor excision, followed by combination therapy of both gamma knife and immunotherapy, and was in the midst of a clinical trial. However, patient actually passed and succumbed a week ago. Yeah. So that was the latest update. So, but all in all, sorry, there's actually another slide. So take home key message here, actually one, lesions that again, like Dr. Marfu'ah mentioned, lung CA, they present to you late, third stage 3 and above usually. Rarely we see it. So you have to have a really high index of suspicion. Risk factors need to be identified early. Diabetic age and the smoking history is key. Diagnosis early is key so that you can intervene early. So again, stage 4 disease is not the end of the line, as we used to say last time, palliative. Now you have a lot of options, especially when you need to identify adeno-CA. You have those mutational drive and now gamma knife. So without further ado, I think we ended our CPC with a Kahoot, and for the medical students, and the last words for our chairperson, Prof. Andrea.
Thank you, everyone. So I know that we are 3 minutes over time. You will still give us a good review in terms of keeping to time. I appreciate that. I think we have learned quite a lot. For the panel, if you can stay back outside, we'd like to take a group picture. Otherwise, Kahoot for the students. Thank you.